Good afternoon. And so today we are planning for actually 3 cases. So this is going to be second one, and next one is ready. As soon as this is over, we'll go for another case. And so any case, any gallbladder, if a patient had a pain, and all of you know about this guidelines, TG 18, no, Tokyo guidelines 18, second guidelines. So it is a mild, moderate, and severe. The patient has only pain, that is called grade 1. There is no other dysfunction, organ dysfunction. And if it is a counts is more than 18,000, and then wall edema is there, and then mass in the right upper quadrant, then it is called grade 2. And then it's associated with the organ dysfunction like liver LFT deranged LFT, and renal function is altered. Then it is called grade 3 acute cholestasis. And most of the time what we are getting is grade 2, and then sometimes we are getting a grade 2. And before going for this live, and if it is a grade 3, suppose you are getting a patient with organ dysfunction, you have to see cardiovascular, respiratory, renal, and the hepatic. If these 4 organ dysfunction, and it is most of the time it is reversible after surgery, you can take up the patient for surgery. That is all cardiovascular, hepatic, and kidney is called, renal is called the positive predictive factor. So even if it is altered, this function is there, you can go ahead with surgery. If the patient had a respiratory function, respiratory dysfunction, and neurology, neuro dysfunction, some delirium or some level of some unconsciousness, dizziness is there, then that is comes under negative predictive factor. So if it is a negative predictive factor, lab chole will not will benefit to the patient. So then we can go for some other endoscopic method, percutaneous or another thing, and then we can treat the patient with the other factors. So this is the preoperative evaluation of Tokyo guidelines with the positive and negative predictive factor. So with this, I'm going for this one. This patient is again 3 days old history, and you can see all this momentum is covering like this. And when the momentum is covering like this, everybody's intention is go and separate the momentum in the fundus. So that should not be done. Sometimes if it is adherent, means you will go in a different plane. You will go through the momentum or go through the gallbladder. Always if the momentum is adherent here, you try to come to the quadrate lobe. So this is the quadrate lobe, and then separate the momentum from the quadrate lobe, and then go to the medial side, lateral side, and then separate the momentum. So this is the way we have to separate the momentum. And this looks around 2 days old history. You can see the lot of edema here, in gallbladder wall edema also there. And some of the, maybe it may go for a gangrene if you leave it for a day. And if a gangrene means the cystic artery get involved by the edema, so it will go for a gangrene. And always when your momentum can be separated with the suction nozzle, it is like our finger, and you can introduce and then you can separate the momentum. So like this. And when you are separating the gallbladder, you can see I'm just holding the gallbladder like this, pushing it like this, suck. So how much pressure you can give, it will come with the practice, and you can tissue should not get injured, but same time we have to get adequate exposure. So that much amount of traction you can able to give. And this can be excised, released with a harmonic scalpel or any other device. And I'm releasing this before decompression, then I go for a decompression. And chief doesn't use energy device for lab chole. It's actually doesn't require, but if it is available, then you can use it for a acute condition. So always give traction and then see the lower blade of the gallbladder, the harmonic scalpel. It should not injure the vital structure. The disadvantage of harmonic scalpel is a lot of fumes will be there, particularly if you are using to the edematous tissue. Okay, so it is released, and I'm going for a decompression. I already is described. So now you can see in the external view, and now you can see this laparoscopic view also. You can see this obturator is coming from the 5 mm trocar. It is in the subcostal level. So what I do, I just take this trocar, and then I'm trying for a puncture. So now I press the gallbladder with the trocar only, not the with the cannula only, not the trocar. Operator is I pulled out. So now I support the gallbladder. I'm not able to hold it. I just supporting it like this. Now I'm pressing it. I puncture the gallbladder. So now you can see I'm taking it for culture. Suppose if you are operating for an empyema or anything, you can take it for culture, close, suction ulla podupo. So just I want to show this. It is very easy way. Instead of taking it through the suction nozzle for a culture, you can take it through the side nozzle of the trocar. So now I am decompressing it. Can you see this? It is getting decompressed. Is it clear? Yeah, okay. So when you are taking out this infected fluid, it's like a mucosal gallbladder, and the suction on, don't close the suction on, suction on. So with the suction on, I'm taking out the trocar. Suction வெளியில இருக்காது. I'm taking out the trocar. You can see trocar is coming out, suction is on. Suction on பண்ணிட்டேரு. Take out. Suction வெளியே எடுப்பு. See, like this. So it is coming through the trocar. I want to show without anything. So the suction should be on all the time so that the content will not coming out from the gallbladder. Okay. புடிச்சுக்க. Suction கொடு. So this is the way of decompression without any fluid is coming out from the gallbladder. You can able to decompress it. Okay. So now, and always try to start your dissection from the medial side. And suppose this duodenum is adherent, no, you are not able to separate, and you can do the type 1 modification. You can able to separate, most of the time it will come. And if it is a delayed case, no long duration or delayed case, then you can able to leave the duodenum, anterior wall of the gallbladder on the duodenum. And when you are retracting the gallbladder towards cranially, you have to see two things. One thing is a liver adhesions. Second thing is a falciform adhesions. No, falciform is sometimes it will adherent to this place, so it will be liver capsule will get that. So we have to release the falciform. If it is a liver adherence is there, you have to release the liver. Suck. So now I'm going take the Maryland forceps with the monopolar cautery for the dissection. So always go close to the gallbladder. So if it is a vessel, yes. Yeah, that is a good question. And usually according to the guidelines or textbook, you have to operate within 72 hours. Even the patient comes to you after 3 days, no, 72 hours you can operate. So that is the guideline says. But what is a gym practice? The patient comes on any day, even after a week also we can do surgery. But within 72 hours, a lot of adhesions will not be there. It will be easily separable. Can you see? It is easily separable. If it is a treated case, treated with outside for 4 days or 5 days, then patient reach you, then technically, you know, the separation will be difficult. So that's why ideal is 72 hours. Acute coli, 72 hours you can operate. So my aim is to take out the duodenum down along with the adhesions. Along with the adhesions, I have to do it down. I'm not going here. I have to find out the infundibulum. And I have to lift the infundibulum. That is the first aim. So the infundibulum is the one. Only in a patient with the biliary pancreatitis patient, the infundibulum will not be there. And if you observe carefully, that gallbladder will straight away go and join to the CBD. That is a presentation in most of the biliary pancreatitis patient. But otherwise, the infundibulum must be there in all cases. Bowel holding suction. So if your infundibulum is coming out, that means posteriorly, if you are clearing the taking out the infundibulum, then straight away you can reach the infundibulocystic junction. That is called safe zone. Infundibulocystic junction is called safe zone, and the CBD cystic junction is called danger zone. So just I want to go in a safe zone, so I'm trying to take out the infundibulum. Suction is a very good instrument, and on and off you have to suck. You have to clear the field. Always the field should be clear, and for that you have to keep a suction. And if you have very much, the distended or some post pancreatitis head plugmon is there, your vision will be altered. Then you can press down here with the additional trocar, so that you can able to get a good view on the calyx. So here I can have a good. I'm having a good vision. I'm not putting any extra trocar. So on and off, you have to clear the field with the suction, then you can continue with the dissection. So gallbladder cannot be moved further. So that's why I'm holding the infundibulum, and I'm trying to get out all the structures from the infundibulum. Yes. Define the infundibulum first. Most of the cases you will able to get it, and you can do the total cholecystectomy if you are going to get the infundibulum. So now you can see that is the edge of the infundibulum here, and I'm going here. And if you go medially, you can see, previously there is no bleeding. Medially the bleeding, now the bleeding is coming, because the vessel will be there medially always. So that's why I'm going laterally, and then I'm getting the infundibulum. So the clear view, because of my little bit medial dissection, bipolar கொடுத்துரு ஒரு காஸ் பீஸ் கொடுத்துரு உள்ள கொண்டு போற. Laparoscopic cholecystostomy, no. Suction. No need. So because that's why I told, if you have a grade 3 acute cholecystitis, even if you see the patient in OPD or in ER, you have to the surgeon should mention it is a grade 1, 2 or 3. If it is a grade 3, you have to look for an organ failure. So if it is a cardiovascular, some BP, hypertension, and then renal dysfunction and hepatic dysfunction, then you can take up the surgery. So that is called positive predictive factor. Okay. And if you have respiratory, then patient required some kind of ventilation, and some neurological dysfunction, if you see, then that is a negative. Then don't advise, even though if you're able to do surgery, don't do surgery, because surgery will not benefit. Surgery, patient mortality rate is very high. So patient, everybody think that because of the surgery, no complication happen. So that's why a negative predictive factor, if you see, then you have to defer the surgery. You can go for a percutaneous aspiration, higher antibiotic, treated with higher antibiotic and other things. No need for laparoscopic decompression of gallbladder. We don't do. Can you see I'm going little bit posterior? I'm separating all the, because the infundibulum of the gallbladder is the one, it is lying on the right hepatic duct. That's why when you are doing a normal gallbladder, regular gallbladder without acute condition, we used to tell posterior dissection you have to do first, because if you do posterior dissection, the infundibulum will come out from the right hepatic duct, so that you can able to, that one way it is safer, no? You will not, chance of getting injury to the right hepatic duct will not be there. So that's why we have to do posterior dissection first. These are all small branches, so it's no need for any energy device. Because of the edema, it looks big. See, that is a stone. Eh? Yeah, I'm able to feel it. This is the stone. Can you see? The entire infundibulum is coming out now. Yeah. So Chief told about the flag technique, flag anterior dissection, posterior dissection is possible only if your infundibulum is in your hand. Okay. So that is the first step in any acute cholecystitis, gangrene or any acute cholecystitis. Now I know cystic duct will be here because infundibulum is coming here and this is the artery. Here without dissection I can tell artery is over the duct. Duct will go like this, artery will be like this. It is not two parallel structure. Okay. I think everybody can understand the anatomy, no? Now? So after infundibulum is coming out, so anatomy is clear to everybody. So that's why that will be the first step in any acute cholecystitis. So now I have to dissect here. If I hold here, I may injure the vessel. Okay. So what I do, I go inside with the closed instrument and then I just open the instrument. Okay. See, open and then I retract. Can you see this? How much exposure? Yeah. This is another way to in acute condition or any other condition, retraction of the gallbladder. Is no need to hold the gallbladder all the time. When you are doing esophagus, no achalasia or fundoplication, we never hold the esophagus. We just retract the esophagus with the adjacent structure. That's why the same thing. You can see I'm just dissecting like this. Very good exposure. I'm not holding the gallbladder at all. But exposure is even if you hold the gallbladder retract, this much exposure you cannot get. So now I dissected here. I'm suction couldn't. Suck. Suck. Okay. So now I'm holding the infundibulum. Can you see this cystic duct here? Yeah, it is very, yeah, okay. So now I'm going for a cystic artery. Hold, sister. I'm going for a cystic artery dissection. I'm going to clip the artery, then I go for a cystic duct. And safety triangle, a critical view of safety, that is the one I am look for here. Dissecting, I just looked it, nothing is there. And here, it is very well, it is going to gallbladder only. So I'm going to divide this artery after clipping. Suction kuduthittu kudu. Always you look for artery of Caillots, it will go from the cystic duct. Suction. And if you see, I'll show it in external view. My inga kami in the epigastric trocar kami, right down money. Can you see this trocar? It is only 5 mm. Hello? Yeah, I'm not making a 10 mm. Anyway, I'm going to have a 10 mm. And if you have 10 mm, now each and every time, you little bit, shaky movement will be there when you are doing a Caillots dissection. Caillot dissection is the one, is prime importance in lap chole. So that's why till I complete the Caillot dissection, I don't put my left hand as a 10 mm. So it will give a good control. 5 mm will give a good control. Whenever I require clip, no 5 mm, 5 mm. Okay. Right hand. Left hand is always 5 mm. Right hand, usually we put 10 mm initially because we need a clip and other thing. But I do only with the 5 mm because 5 mm means instrument control is so good compared with the 10 mm. 10 mm, some slight shake movement will be there. And after, yeah, because the instrument size is, trocar size is larger than the instrument size. So that's why still the Caillot dissection is over, I don't put a 10 mm trocar. So here, I'm going some more dissection before changing the trocar into 10 mm. Almost all case, sir, all case. Whenever we are going for a clip, then we change to 10 mm. Otherwise, all lap chole will start with this 5 mm only, sir, because it will give a very good control. Yes, sir. So all the level we are making this. This is the artery of Caillots. So I used to tell my PGs, Hutch, number Hutch, like Hutch. Sometimes the artery, most of the time artery will be here, duct will be here, it is like a Hutch. Now it is here, this side. So I'm going to divide this artery with the harmonic scalpel. Then only I can get the entire full access of the vision of the duct. Yeah, sister. Now you can see how I'm retracting the gallbladder. I'm not holding and then retracting the gallbladder. Just I am, yeah, spread and then I push the gallbladder. So here and all in acute cholecystitis, any gallbladder, no, the harmonic scalpel will be helpful. This type of small vessel dissection division can be done with the harmonic scalpel. Otherwise, I required clips or bipolar I can apply, but lateral spread is more than the harmonic. Suck. Suck. So now these are all the small vessel covering the cystic duct. That also I am going to skeletonize before going for a clipping. Hey, Mathivi, foot pedal. Can you see this? Another branch is going to the cystic duct from the artery. It is the origin of the artery is going. And I'm not dissecting with the harmonic. The harmonic dissection is not advisable, and always do with monopolar. Then because harmonic, the lower blade will injure the deeper structure. So that's why any vessel, small vessel division, you can do it. Otherwise, dissection with the monopolar cautery is a better one for a safe dissection. I think it's very clear. The safety triangle also I can able to see it from here. Uh, that is a vessel. Okay, sir. This normally it will be like this. It's not very much big. So I need some more posterior dissection to see the safety area. Huh? Always we learn from chief sir. We don't use this one hook in callets. Any gem doctors they don't use because we feel this monopolar will give a better control than the hook. So a lot of small vessels are there. So I'm going to divide this. Then I'm dissecting this. Can you see this liver surface here? Safety triangle of safety also is achieved. This is another small branch. So even in it's not possible in all cases. Safety triangle critical view of safety is not possible in all cases, but as much as possible we try to make it. So can you see this? This is no any angle I can rotate and then I can take it small tissues. So the entire duct is getting skeletonized very nicely. And this looks artery. Whenever required, I can able to clip it also. I'm dividing this. Then I'm going for a clipping. புடிச்சுக்க. வேணா அப்படியே இருக்கு. Since this liver surface is coming in the view, I'm taking this because lower, even though I'm not seeing the lower blade, and I'm very much, no, it is not touching anywhere because the liver surface is there. I'm not quite I can able to divide this vessel, small vessel, but I'm not doing it. பிடிச்சிக்க சக்ஷன் கொடுத்துருப்போம். நெக்ஸ்ட் கேஸ் ரெடியான்னு கேட்டுக்கங்க சார். சக். So all these things, Callat's dissection, everything is possible without any much bleeding. The only one step I can say is the release of mobilization of infundibulum is making all this thing happen. Yeah. So that point I want to tell you further. So now I'm making my incision in the epigastric port to 10 millimeter. I'm taking the 10 mm trocar. So I'm going to put clip. It is a medium large clip. That is a medium large means it is a green color clip, 9 mm clip, basically 9 millimeter clip. So I'm putting only one clip. One more. And then I'm dividing with the harmonic scalpel. I'm not putting any clip on the specimen side. Even one clip is enough. You can divide with the harmonic. In acute situation, I'm putting one more to the cystic duct, cystic artery. Relax, konja loose. 5 mm distance would be there when you are using a harmonic. So now I can have a better vision. And Maryland Kudu, I'm trying to see the cystic duct CBD junction is not required. No, it should not be. Once you are having a adequate space to clipping, then you can clip the cystic duct. But just I'm seeing. And in our hospital, subtotal incident of subtotal cholecystectomy is getting very much reduced because we are following all this technique. And some of the difficult cases, I'm using a laparoscopic ultrasound. For a gallbladder surgery, I'm using a laparoscopic ultrasound for some of the difficult cases. So I'm not going for a subtotal. Now you can, it's very clear. So the CBD is here, must be here. This is the CBD. Only thing this I can able to take it, but you can see a lot of small vessel I have to coagulate. Again, that will go to the CBD side. So I'm not doing this one. Okay. Is it okay, sir? Yes, sir. Yeah, I'm going to clip it. Just milk out. Maryland holding. Yes, sir. Yes, sir. Yeah, lap ultrasound. Suppose this patient, the stone is in the infundibulum. It is like a type 1 Mirici syndrome. And then, yeah, Mirici, then I can do lap ultrasound to see any CBD stone or left any CBD stone or not. That is the first thing. Second thing, if it is a very dense moss-like cystic, there is a frozen calyx, I'm not able to skeletonize the structure, then I can open the infundibulum, then I take out the stone, then I do lap ultrasound to look for any stone left behind. So now you can see I'm taking a hemolog clip. This is a 13 mm hemolog. So I'm just checking and I'm not pulling, just I'm leaving and then I'm checking. Say I'm push the duodenum down, I leave the cystic duct, I'm checking whether any tenting of CBD is there or not. There is no tenting of CBD, I'm applying here. That also I'm not going down. Can you see? I'm not going down. There's no need actually. Yeah. Normal. Yes, sir. Yes, sir. So you can put a regular clip also, but a sister loaded this clip and I put 2 clip on the CBD side. So now I'm taking this large clip. This is a 11 mm clip, otherwise called yellow color clip. So if you hold the infundibulum and if you hold it like this, you will not see the distance between the 2 clip. Okay. So for that, I do like this. Can you see, sir? So now you can see how distance is seen very well. So I can go up and then I can apply the clip. So that is the way. Reverse last clip, instead of loading like this, you can reverse it. So it will be nice. So I'm not using any energy device for this division of cystic duct. And the clipping also always, we used to keep 3 clip. And I used to name the clip routinely. So the clip on the cystic duct, CBD and cystic duct junction, that is called definitive clip. Definitive clip. When you are applying this clip, you should be very much confident that this is the cystic duct only. That is the first thing. Second thing, before applying this definitive clip, see the clip whether it is properly loaded or not, and then just see the duct size and the clip size whether it will match or not. Before applying clip, you have to see the 2 things. This is the definitive clip. Then this is called additional clip. The definitive clip, additional clip distance may be maximum 3 millimeter. Then this is called sentinel clip. Between the additional and sentinel clip, 6 mm distance would be there. Is it clear, sir? Yes, yes. And then I'm not dividing like this. Again, I may go close to the additional clip. So I rotate like this. I don't want to. I want to keep around 2 to 3 mm tissue on the CBD side, not on the patient side. So I'm just dividing like this. And then once I divide, immediately we have to see this should face laterally. It should not face anteriorly. If it is face anteriorly, that means it may be the right hepatic or the CBD. These are all the points. No, initially any mistake done, we can note it down initially. Yeah, suck. So now the job is done, and only thing we have to look for posterior branch. Most of the time, gallbladder surgery, Maryland, gallbladder surgery, bleeding happen from the posterior branch, not the anterior cystic branch, because anterior branch is in the view, posterior branch is will not be in the view, so it will be bowel only. So I'm looking for a posterior branch. If it is any posterior branch is there, I don't believe any energy device. Any posterior branch, small or big, anything is there. My preference is go for a clipping. Then I proceed for a gallbladder mobilization. Okay. This also, it looks some branch, and I'm going to clip the vessel. Then I divide this with the harmonic scalpel, and then I go for a gallbladder bed removal. And any vessel here is there. And then after while mobilization, then I can able to see whether it is required any clipping or not. It looks a vessel here. After clipping this vessel, I can able to see that looks a main vessel. This is the branch vessel. So the liver is coming in the view in between, so I'm not able to coagulate. Who கொடுத்தறியா இல்லை இதிலே வருது. So always look for a posterior branch in all the cases. If it is a anterior branch, this one is very small, then you can go for definitely posterior branch will be there. If anterior cystic artery is well much adequate, then you can go with the suction கொடுத்துட்டு clip கொடுத்துரு. Post-operative bleeding, everything is happened because of the posterior branch of the cystic artery. So I'm putting a medium large clip, that is a green color clip, 9 mm clip to the cystic artery. Usually the artery 7 mm white color clip is there, that is called a small clip, but that separate clip applicator is required. So most of the time we are managing with the regular medium large clip. So just the peritoneum, so much thick, no, because of the inflammation, it has become thickened. Yes, Sandeep, yeah. Yeah. Yes, that is a very well point. Not only lap chole, any surgery, the surgeon is using their left hand is effectively, then he's a good laparoscopic surgeon, I can say. And so, where you are dissecting, the exposure is very important, and you can manage with your left hand. Now you can see this big artery here. Can you see this? Yeah, that I'm going to clip it. Then I can proceed for this one. So the left hand, and I'm not holding the anterior wall of the gallbladder all the time. I'm going the lateral wall of the gallbladder, sometimes posterior wall of the gallbladder. Anything can be done with the left hand instrument. கொஞ்சம் bipolar கொடுத்துட்டு liver bedல இருந்து. No, this is a it depends on the exposure. And if it is a main stem can be easily approachable, then I can go with the main stem. Otherwise, I can do with the branches. So that is a little bit is gone through. Harmonic. So some gap is there. There is a small branch. It's getting torn and then bleeding. I'm going to apply clip here. So I thought of encircling with the clip, but it's only this is possible. Clip கொடுத்துருச்சு. I'm not using harmonic scalpel, even though if I have, because posterior artery means always I recommend clipping. It is not applied properly because there is no posterior tissue is not there to take up the clip. But anyway, it is occluded. I'm going to divide with the harmonic scalpel. So that's what I want to dissect this here. That means I can introduce the entire clip is inside. Okay, next case ready? 5 minutes. Okay. So now I'm dividing the feeding artery, posterior artery. And after division of the artery, if you have harmonic, you divide this here. After division of the artery and duct, you will have now you can see it is easily coming the posterior posterior side. Then you can have a hook. Hook is a better instrument. Suction hook, better instrument, or you can use a spatula. Initially we use spatula. Nowadays we are using hook. Anything is good one. No need for energy device, harmonic or ligature to take up the gallbladder. வாஸ் கொடுக்க முடியுமா கொஞ்சம் So just finish the calyx, clear the field, just see whether you have done correct or not. Any doubt, if you are 100% sure, then you can go for a gallbladder, because till then the gallbladder will be there for a traction, so that the calyx dissected area will be exposed nicely. Once you take out the gallbladder, then you are coming here means no exposure will not be there. Suck. Small bleeding is coming here. I'll see after that. So this is the dissected area. Now I'm going for a suctioning gallbladder mobilization. In acute condition, we can go in plane, in the cystic plate plane, so that gallbladder mesentery is there. So we'll take the entire positive wall of gallbladder, or we can go for a type 1 modification. Type 1 modification is leaving the liver bed, leaving the post wall of gallbladder on the liver bed. That is the one thing. Suppose if a duodenum is adherent, when you are starting the surgery, duodenum is adherent, you are not able to separate the duodenum from the gallbladder, then you can leave the anterior wall of the gallbladder on the duodenum. So the type 1 modification is leaving the anterior wall of gallbladder on the duodenum, or leaving the post wall of the gallbladder on the liver bed. After that, excise the gallbladder, then you can go for a mucosectomy. You can remove the mucosa from the post wall or from the anterior wall. Then it is called type 1 modification. Type 2 modification, otherwise called a difficult liver bed. Type 2 is a difficult hilum. You are dividing the infundibulum, then leaving the taking the mucosa of the infundibulum, then suture the infundibulum close to the cystic duct. So now you can see I'm going close to the gallbladder, and camera surgeon is not rotating the light cable. He's keeping it very straight only, because I want to see here. I'm retracting the gallbladder. I hold the post wall of gallbladder. I'm retracting it. There's no need to rotate the camera. Okay. So everything left hand is as Sandeep told, left hand is the key for this any surgery, and left hand movement is very critical. One the surgeon should learn how to use the left hand. So again, I touch the gallbladder, exposure is there. I'm holding, and then I'm seeing like this. So the other side of the edge of the gallbladder I can able to see. I'm taking like this. So now I'm rotating the gallbladder like this. So now I'm holding the lateral wall of the gallbladder, not the post wall, lateral wall of the gallbladder. And here it is liver bed, some is coming because I'm trying to take the entire post wall of the gallbladder. If it is a liver is getting tear, then I leave the post wall. I can have I can take only the mucosa of the post wall. Here it is gone into deeper plane. So again, I shifting my left hand instrument, and you can see in the external view, my shoulder is not a shoulder strain. My shoulder is very relaxed way. I can move up and down. I can rotate my left hand sideways, and then you can see I'm not holding my left hand. If you focus close up focus my left hand. So I'm not introducing my finger into the hole in the instrument. I'm just holding the instrument. I'm not introducing my finger into the instrument. Now, see, pulling out, so it will give a good exposure. So here also I'm going little on this side. I'm not going on the liver side. So here only the plane got disrupted. It looks like mucosa is coming out. Serosa is left behind. Veli sister. So type 1 modification done. Veli sister. Valaya. Tokar veli first. Sure, okay. So now the entire gallbladder is taken, and here you can see some liver bed is being exposed, and I'm going to coagulate. For that suction கொடுத்துரு எனக்கு ரெடியா இருக்காரா ஒரே நிமிஷம் சொல்லிட்டு So now you can see I'm just coagulating because bipolar is coming from my left hand, so that it will be perpendicular to the liver, parallel to the liver bed. So entire by காற்று increase பண்ணிக்க entire liver instrument is touching the liver surface, the coagulation will be good. If it is coming from right hand, so only the tip of the instrument will touch the liver bed, and we have to coagulation will not much effective. Is it clear, sir? Yeah. Yes, yes. So I'm just chief sir is ready with another case. இது எப்படி instrument டொக்கர் எப்படி bowl holding put. And another point I want to tell, when you are washing the liver bed, and so you can see I'm just retracting the left hand with the colon or a duodenum or any momentum structure here. So then I retract the gallbladder like this with the suction nozzle, and then I'm irrigate the saline. The entire liver bed is washed with the saline. Once this cavity is filled, now I'm so again I'm doing like this. Can you see my left hand is, I'm not moving my left hand. I can do it. I can wash the liver bed multiple times. So this is the way your injury up to the colon, momentum or duodenum will be avoided. And then putting saline like this, here it is not useful. Our aim is to wash the liver bed. So entire liver bed is getting washed, and exposure is also good. I'm not injuring any structure because my left hand movement is very much minimum. So this point I want to tell. So I think I told all the points. So any other thing you have to tell about this surgery, sir? So only thing, I'm going to put it in a plastic bag, and then I divide this into 2-3 pieces. I'm taking it already. Chief sir shown the technique, and I think you can go for a next case. Thank you so much.